Good morning, everyone, and thank you so much for joining us today on this webinar. My name is Richard Stubbs. I'm Chief Executive of the Yorkshire and Humber Academic Health Science Network. Thanks so much for joining us. The purpose of today's event is to allow us to listen to some speakers and think about and discuss how we want the healthcare system in our region to look as we live with COVID-19 and how we can understand and adapt the best COVID-19 related innovations into everyday working practice. Just a bit of housekeeping from me before we start. You'll probably all have noticed that you are all muted for the duration of the webinar. We have over 400 delegates joining us this morning, and so we do want to obviously to be very interactive, and we've got quite a lot of time reserved at the end for questions and answers. So if you do have a question, please do type it into the chat box. Hopefully you can see that in your display. And as you do so, in time-honored tradition, if you could include your name and organization as well, that would be fantastic. You don't have to wait until the end to type in your question. If you type them in while the speakers are presenting, we'll be capturing all those questions and trying to get through as many as possible during the Q&A at the end. Also, if you do need to leave for any reason, just let you know that obviously all the slides and the presentations that you see today, but also a video recording of this webinar will be made available to you before the end of the week, and you'll get an email on those details shortly after this broadcast. And obviously, as you'd expect, we are live tweeting during this event using our Yorkshire and Humber AHSN Twitter handle, which is @YHAHSN. And we'll also be using the hashtag NHS Reset. So if you do want to interact during the event, we do encourage you to be using Twitter as we go forward. But also, I think trying to keep this discussion and debate going way beyond the webinar and using the hashtag NHS Reset to do so. I hope you enjoy it. I'm really grateful to be joined by an incredible panel of speakers today. We have in very shortly Katherine Ward. Katherine is Chief Commercial Officer for a fantastic innovative company called Healthy.io. Michael Wood. Michael is Head of Health Economic Partnerships at the NHS Confederation, and Rob Webster. Rob is Chief Exec of the West Yorkshire and Harrogate Health and Care Partnership, amongst many other titles. They'll be joining us very shortly, and Michael will be giving us his presentation first in a few minutes. But first, from me, it's an obvious statement to say that our health service has had to undergo rapid changes through this immense challenge that we faced as we first flattened the curve, and now as we look to live with COVID-19 for the foreseeable future. By way of example, there has been many transformations that the system has seen in the last 4 months. We know that GP face-to-face consultations have reduced to only 8% after being about 80% before COVID-19, due to the rapid implementation of video consultations in primary care. We know that public use of our digital services has hugely increased, and by way of example, between January 2019 and February 2020, there were 236,000 requests for repeat prescriptions via our NHS app. Since the 24th of February 2020, that's been 100,000 alone and continues to rise. And in terms of the way that we work, Microsoft Teams has now been rolled out to 1.25 million NHS staff in just 1 month. But not all these changes will prove to be beneficial. Many of them will. As an HSN, we're working with our NHS and care partners in the region, and we've found this framework by Ian Burbidge at the Royal Society of Arts very useful in helping us to think through how we first evaluate the changes that have been undertook as a result of the pandemic, but also how do we start to learn the lessons and amplify some of those benefits. And of course, it goes without saying, the top right box, as you can see here, about amplification. It's about finding the new practice, the disruptive changes in pathways that have been born as a result of necessity, but actually show amazing promise for the future, need to be understood more, need to be evaluated more, but then can be rolled out at scale. But equally, it's the bottom left-hand box, which is just as important. We're not very good as an NHS at decommissioning old services. And as we think about how we reset our NHS, we also need to think about what we need to stop doing, as well as what we need to start doing. As an NHS network, we work locally in all our patches across the country to support our local systems, to understand these changes, to evaluate the transformations, and to spread the best practice. But we also come together nationally to share that best practice, spread across our respective geographies, and obviously influence at a national level in terms of how we take these systemic lessons of spread and adoption and embed them into our policies for the future. So what does that look like? Well, at a Yorkshire and Humber level, we've been working with our colleagues in North East and North Cumbria, AHSN, so therefore put a programme of work that's been across the North, East and Yorkshire NHS region to do some regional evaluation and reset work. In the immediate short term, that has meant doing some qualitative, rapid insights at an integrated care system level and finding the innovations that have emerged, looking at how they were used and looking at the change in practice needed to embed and sustain them. Over the medium term, it's about moving towards a more detailed evaluation and assessment, and we'll be publishing and promoting these exemplar case studies to share our best practice. And in the longer term, this will be about an academic evaluation of the insights and developing action plans, but also working with our integrated care systems on the implementation of their sustainability plans for their priority areas. And we won't be doing this alone. There's a new campaign that we're very proud to partner with the NHS Confederation and the Health Foundation. And Michael will be saying a lot more about that. So let me introduce our first speaker. So Michael Wood is Head of Health Economic Partnerships at the NHS Confederation. Michael has supported NHS organisations to understand and influence local economic landscape since November 2015. And prior to this, he was a Senior European Policy Manager at the NHS European Office for more than 7 years. Michael works closely with the range of national and regional NHS bodies to support their planning on issues as diverse as population health, finance, estates, infrastructure, innovation and skills and workforce. And he's also a huge friend of Yorkshire and Humber AHSN. In 2 weeks, Michael and I will be publishing a major report for Yorkshire and Humber on levelling up the importance of health and the importance of wealth on that agenda. Michael, thanks very much for joining, and I'll hand over to you.
Thank you, Richard, and good morning, everyone. And that was a great platform, I think, Richard, for what I'm going to say, and I'm sure what the fellow speakers are going to say. So today I'm here in my NHS Confederation role, and I think, you know, I really want to focus on the NHS Reset campaign, which Richard set out so ably. We went live on the 1st of May with NHS Reset, feels a long time ago now, of course, and we hope this will really form a major part of the contribution to the public debate on what the health and care system should look like in the coming months, but also in the aftermath of COVID-19. This slide here in front of you, I guess, is just me trying to take us back to reflecting on how April felt. I'm sure many of those joining from home will look at these points and nod and understand that actually, you know, wherever you were in whatever sector, hopefully these points resonate. You know, this is a national picture I'm giving, and you know, and of course the impact and timing of nature differed slightly, but by and large, what we saw was rapid transformation. We saw barriers lifted, we saw national confusion, perhaps more of that later, and we saw real innovation and change on the ground. And what was fascinating was, you know, the timing was incredibly difficult and challenging for our members at the NHS Confederation. And yet, even in those early days, our members were telling us that actually there needed to be some national thinking about what was going to happen in the coming months and what we could do next. So just moving on to the next slide is where we start looking at what the members told us. two central reasons, I would say, why members were so keen for us to start doing our early thinking in what was an incredibly difficult period. And if you look at the second and third bullet points on this slide in front of you, the leaders, our NHS leaders, our members, told us that this wasn't a recovery as far as they were concerned. They weren't trying to get back to the same place they left. And trust me, I dug out the Oxford English Dictionary and looked through very many R words, but actually reset seemed to be, to me, to the Confederation, to our members, as the kind of symbolic words which actually more crystallise what we wanted to do. I think as part of this, our members wanted changes to be captured. They wanted a public debate on what the system can and cannot achieve going forward. I think that's really important. The opportunity there, reset faces two ways, nationally and locally, and this is both critical. So if we take the national perspective, for example, there are various naturally important national bodies we want to influence through NHS Reset. Of course, this includes NHS Improvement in England and how they go about their own version of Reset. And we want to make sure what happens nationally in the NHS is not too technocratic and top down and focused on business as usual. But we also want to look at government, and we know there's a review going on led by Number 10 looking at feeding into the spending review later in the year. We want to pitch public services in the NHS as a real investment and feeding into that work. Locally, and we've got Rob Webster after us, locally really important that we're supporting systems to develop their own reset plans, through our work and also through the Confeds networks. And two more points I would say on this slide. The one is the early conversations we had in members was absolutely fascinating. There was no rushing to try and work out what the answers were. Many of our members said, actually, we don't even know what questions to ask yet. So what I got initially was just personal reflections, which I found incredibly powerful. And the other thing I would say is Reset's not about ripping up the long-term plan, quite the opposite, actually. This is about how we accelerate change and deliver that vision. And we've included a web link on the bottom for people to click onto and look. So if you move on to the next slide, much of the detail of Reset has been developed through 10 themes. The first 6 are on this slide and the 4 on the next slide. I don't think the headings for these themes will come as a surprise to anyone joining the webinar. Clearly, there's an awful lot of overlap between and across these themes. Each theme is producing its own work, which will then feed into an overall reset report, which will probably come out in September time. So, I'm sure people joining the webinar at home will have an overall interest, but perhaps might have an interest in one of the particular themes in this and the next slide. You can go onto our website and find out what's happening. And if we go on to the next slide with the other 4 themes, I'll come back to the two circled there, which I think are particularly interest for today. But I do like to draw the attention to the last theme there, a new relationship between the NHS, public service and communities. This is sort of, I see this as almost that black box of innovation. Actually, I'm not quite sure what will come out of it. But today, our chair, Victor Adebowale and Donna Hall are leading a roundtable discussion on that. Some really fascinating conversations happening where we want to bring some lessons out. But for me, I think today, Richard, just focus on the two themes which are circled. And if we go on to the next slide, I'll come back to those. Because I think it's really important. I just refer to some early common focuses coming through in every themes. And again, these, probably people joining are probably quite reassured that the points I'm making here. So in all of the 10 themes, what's coming across our desk, which are common strands? Let's start with digital. Richard's mentioned already some of the digital transformations, particularly in primary care, incredibly impressive. My chief executive, Confed, talks about how it can be virtual by default in some areas going forward. Health inequalities, not only a passion of the Confed's chair, Victor Adebowale, but I remember less than a month before lockdown, sitting in a room in London as Professor Sir Michael Marmot published his report. Now, I'm pretty sure the issues he raised are probably even more prevalent now. So a real challenge for us. And of course, we also look at the prevailing inequalities in how we treat our own staff in the NHS. Culture's in there because ultimately this determines whether there is any change. Agility, particularly in terms of regulation and governance, and actually how do we maintain the speed and nature of decision making that we've seen in a more structured way going forward. That keeps coming up and being raised. Local leadership, I think one of my favourite quotes from the work we've done so far and the meetings we've had is from a chair of an NHS trust not far from Yorkshire actually, whose comments was along the lines of, if the NHS doesn't get localism now, it never bloody will. Not Churchillian perhaps, but actually that struck me as something which really shone a light on how we are now seeing things through a different lens. And the last point there, of course, system thinking, vitally important. And actually, as we're hearing, there might well be legislation on the way and a renewed look at issues such as accountability and subsidiarity. I've included there some pictures of some of the briefings were published underneath Reset. There's another one came out yesterday. Please check on the link. There's an awful lot happening. If we look at the next slide, I just want to touch on innovation specifically in that. Keeping innovation at the heart of Reset, and I think innovation has absolutely been at the heart of the change that happened at the outset. Richard referenced in one of those themes, we're working with the HSN Network, the Health Foundation, the NHS Confederation, and we've been coming together to understand how we can work across the system to try and realise and adopt the innovations which we believe have a common place in everyday practice. We're working with our clinical leaders, our chief executives, our innovators and industry leads to understand how we can retain, adopt, reinstate or stop what we're doing and for which populations and settings, which is absolutely vital. And also how we can build on the rapid process to, as I say, accelerate the delivery of the long-term vision. And if we look at the next slide, we go into some of the parts and aspects of this in particular. Three main parts to what we'll be doing in our work and what we're doing at the moment, keeping innovation at the heart of Reset. The first is, it sounds relatively straightforward, what's working well, identifying and understanding what's working and for whom. Some early feedback on that, actually is about how on earth do we balance the need for that rapid evaluation of change and that change which needs to happen in the coming months with also perhaps some of the longer term systematic change and how we enable leaders to evaluate the here and the now, but also put in place some longer term measures. And there's a fascinating roundtable we're putting in a diary to understand how we can support that piece of work. The second of those bullet points, really interesting. I mean, if you think about the additional resource the NHS has had, perhaps the mindset change, the risk appetite, lots of barriers have been lifted. Well, actually, what happens when the extra resource runs out? What happens when business as usual comes back? It almost feels like there's a race in my mind to try and systematize some of the innovation we've seen and how we change that practice and mindset. And we will be looking at that through our work. And the last of the 3 points, utterly vital. We've just heard about, in the last slide about the value of system working. We saw the critical role care homes played in the first peak of how they were affected by COVID, and actually we've seen an awful lot of innovation in care homes. And I think that's just an example actually about how this cannot be a hospital-driven innovation spotlight. This is about the system, and it's about how it supports the system development going forward. So I think 3 fascinating areas there. And if we move on to the next slide, I wanted to reference through my day job, as Richard referenced, head of health economic partnerships at the Confed, the other theme on that list I circled, economic and social recovery. And as part of this job, part of this work, I've been doing an element of crystal ball gazing, which is really trying to understand what's happening outside the NHS, which might have links and impacts on us, and particularly with innovation hats on. Again, hopefully these bullet points, it might make sense to people joining, or it might just crystallize some of their thinking going forward. But if we're looking at with an innovation lens, actually how strongly will health feature in the wider economic recovery of our country? What opportunities and responsibility does this bring for us, whether we sit here with an NHS, a social care, a local government, a university, or an industry hat on? How will health R&D align with inequalities and the levelling up agenda the government tells us it's still focused on solving? I mean, what will the COVID impact have on universities, which are, of course, one of our utterly critical local partners in terms of how we support and sustain local innovation networks? And, what is the future of industry in this country and how can we support that? So I think what I've done there is just try and crystallise several bullet points of what I can see being on the political and economic agenda going forward. And and really, I guess I'm fascinated in the responses to those and how people feel that should shape what we do. And if we move on to the next slide, I've given a sneak preview here, Richard, of something which I'll be publishing next week with my Confed hat on, actually, which in my book is what we can do in health and care sector to support this wider economic recovery, of which innovation again will be at the absolute heart. And I'll be publishing, as well as this infographic, some bullet points and over the coming months some reports and suggestions on all of these areas about how health and care can get on the front foot and support that wider place-based recovery, which I know, for example, Rob is so heavily invested in locally, which is so powerful and so important. So this is a sneak preview, and more to come on that next week. I'll make sure to share it. And if we move on to the next slide, which is my last substantive one, I suppose the question there is about the window of opportunity. We discussed at the outset that this isn't about changing the long-term plan, quite the opposite. This is about accelerating how we can deliver it. But fundamentally, for me, there's something about how we engage and empower local systems and leaders in the coming months. How can we maintain innovation seen to date? And that's a mindset thing as much as it is resources, risk appetite, clinical leadership, experimentation. What happens when the pulls of business as usual take over, and how can we work with partners to embed innovation in that? How can we see NHS reset as part of courses of a wider placed reset? Are we supporting, influencing, aligning where appropriate, where it's our responsibility on the front foot? And the last point for me, I guess, is a mixture of the Harold Macmillans and the Donald Rumsfelds. What does the future hold? I don't know. I think we have to be upfront about this. Actually, we need to be agile in understanding what our role is and the impacts on us and what we do and how that relates to others and how we can work together for best effect. So that's it for me, Richard. On the next slide, people have got my details and my Twitter handle, or we can send that separately. But looking forward to the discussion. And yeah, I hope that makes sense as a starter for today's discussion.
Michael, thank you so much for that. Brilliant as always. We'll see you in a few minutes in the Q&A. There's questions already starting to come in, as you'd imagine. If you've been inspired to agree with or challenge Michael on any of that, please do use the chat box and get your questions in, and we'll be moving on to questions at about 5 to 12. Time for our next speaker. So Rob Webster joined the South West Yorkshire Partnership NHS Foundation Trust as Chief Executive in May 2016. And he is also the lead chief executive for the West Yorkshire and Harrogate Health and Care Partnership, which is the integrated care system, or ICS, for the region. Rob's worked in healthcare since 1990 and taken on many national leadership roles, including at the Department of Health on policy transformation and delivery. He's been a director for both the Prime Minister's Delivery Unit in the Cabinet Office and a national public-private partnership. And of course, Rob was chief executive of the NHS Confederation between 2014 and 2016. I could obviously go on with Rob's many, many important roles, but I want to highlight the work that Rob's leading on in the integrated care system for West Yorkshire and Harrogate to support BAME staff, public and patients, particularly given the stark statistics of how this pandemic has amplified health inequalities in our communities, something I'm sure Rob will be talking about. So Rob, thank you very much, and I'll hand over to you.
Thanks, Richard, and it's good to see you and everybody else who's on the session today. So I've got about 10-15 minutes to talk a bit about what we're doing as a partnership, give you a bit of reflections from what things have been like as a trust, and to talk about what we might be doing next. So if we start with the first slide, I think just returning to a theme that Michael brought up, really. As a partnership, we're one of the biggest in the country. It's a true health and care partnership, our integrated care system made up of local government, the NHS, communities and the third sector. It doesn't matter if you're a commissioner or a provider, everybody is part of this partnership and everyone's an equal partner. The ICS itself, the partnership, is a servant of the partners. We're there to do the bidding of the organisations in the partnership to deliver the best outcomes that we can for local people. very ambitious in the way that we do that and have been for the last 4 years. So our plans that we produced based on engagement in neighbourhoods and places with people are really there to be ambitious and address some of the issues that have been exposed by the coronavirus. If we move on to the next slide, one of the things we did earlier this year was to publish our 5-year plan, and as we all know, we're required to do hundreds of things literally by regulators, and we wanted to say, okay, in and amongst all of that, what are the 10 big things that we're really going to be known for? And the first 3 are really about tackling health inequalities generally, tackling the health inequalities that bedevil people with learning disability and mental illness, sorting out childhood obesity and improving the health of people who live in poverty, and those sorts of health inequalities issues, which are one of the fundamental parts of what integrated care systems are for. The next 4 really are clinical, so they're about some of the big killers: cancer, you know, the way that strokes affect people, suicide being the biggest killer of young men, antimicrobial resistance, which could be a massive issue for us all in the future, and maternal health and stillbirth were the 4 big clinical priorities we want to resolve. And then 3 things which don't really get much chat in the debates about what integrated care systems are for. Firstly, having a more diverse leadership which represents the populations we serve. Change the people, change the conversation, have a different kind of outcome. Next, you know, we want to be a global exemplar in the climate emergency. That's not gone away. And the green economy and being a positive force for good in that arena is essential for us. And finally, recognising that investment in health and care is part of economic growth. Move on to the next slide. Some of that last point is based on work done by Leeds University, which showed in 2018, if you looked at the assets available to us in the Leeds City region, which is pretty much coterminous with our integrated care system, there is, you know, an opportunity here to do something globally significant. You know, we already have 22% of the UK's health tech jobs, and Leeds University's assessment was there could be about £1 billion worth of economic growth in this area, and about £1 billion worth of productivity and efficiencies that we could gain if we were serious about it. Move on to the next slide. That's one of the reasons why, as part of the local health and care record exemplar, and as part of a significant digital manifesto that we've got between all partners in Yorkshire and Humber, we've got a digital ambition which says we want to be the best place for health data and research, we want to be the best place for digital health and wellbeing, we want to be the best place for the health tech sector to grow and thrive, and we want to be the best place for digital ready leaders, workforce and people. And within that people point, we're looking at, you know, citizens who might otherwise be digitally excluded, we're looking at citizens more generally, we're looking at staff, and we're looking at organisations. So we need to make sure that we're trying to deliver that. So all of that was in place, all of that ambition was there based on the evidence of what was possible, but also what was needed to tackle some of the shocking inequalities that persist in our area. And then coronavirus hit. So move on to the next slide. We know that it's easy to forget 100 days after lockdown. The first phase of coronavirus was one of exponential growth in the impact of the virus. You know, exponential growth, trebling, quadrupling daily in terms of the impact, and we're racing to keep ahead. And we're currently in phase 2 of this COVID pandemic, aren't we, which is really about stabilisation. We're getting used to this way of working, and now we have to plan for the future. But just to give you a sense of what that felt like in terms of having to deliver care during that first phase, if you go on to the next slide, you can see that at the height of the pandemic, these are the data for absences in my trust. The height of the bar is the overall absence, and the colours reflect people who are shielding, is the orange one. Dark blue is people who have household symptoms, light blue is people who are symptomatic themselves. And what you can see is that at the height of the pandemic, at Easter, mid-April, we had 10% of staff absent. And that's before you put on top of that sickness absence. And then you've got people working from home substantially. And that figure has reduced over time, but is still with us. Now, the response to that from staff, service users, the public was pretty magnificent generally, and it was digitally enabled. So if you go to the next slide, as a trust, we were fortunate that we were in the middle of an upgrade to Windows 10, and that we'd spent a couple of years on our infrastructure, really dry, boring things that most people are not interested in at the board, about servers and so on, but really helped with us. Because what happened was, in the floods last year in Calderdale, when people couldn't get to work to look after folk, we had about 600 VPN contacts through our staff. At the moment, we have about 5,000 a day. So what we did, we've fundamentally changed the way people connect with each other and deliver care. And just to give you an idea of the scale of that, the June figures for digital technology utilisation in the trust. Remember, we'd never used Microsoft Teams before, but 75,000 messages sent, 15,500 meetings, 9,200 calls, and about 1,000 group calls using Microsoft Teams in June. In the week of the 19th of June, there were 863 AirMid consultations, 800 AccuraX consultations, 734 Teams consultations, and 147 WhatsApp consultations. Whole services went digital, like IAPT and our liaison and diversion services for people in the criminal justice system. And clinically, operationally, administratively, people have embraced this in ways which we need to think about continuing. At the same time, running an acute mental health trust, we've got vulnerable people with a learning disability or severe mental illness who were not allowed outside of the ward, who were not allowed visitors. So things like virtual visitor and Facebook portals have really helped to connect people. And we've been sharing out System 1 data since April using the new coronavirus powers to ensure that we can connect the information together, which is fundamental to ensuring that we overcome this pandemic. So that's just one aspect of some of the service delivery changes that we see as a trust, and that's been seen right across West Yorkshire and Harrogate in the acute sector, in the community. GPs have gone digital, a substantial amount of digital work and service delivery changes. What I would say in all of that is that the human touch and face-to-face consultations have continued, and they've continued with a very human element to them. So if our memory service, for example, needs to assess you if you're vulnerable, you've got dementia face-to-face. If you are vulnerable and you have dementia, then you may be fearful of somebody in full PPE turning up at your house. So what we do is, as we're approaching your house, we will give you a call, and then the staff will stand at the window without any PPE on and introduce themselves so you can see their face before you have the consultation. So we've continued to make sure that people have got access to face-to-face services, and the human element of that has continued critically. And that's part of something, if you go to the next slide, in the midst of these historical times, if you took a Hollywood view of what was happening, if you want to flick on to the next slide, if you took a Hollywood view of what happens in outbreaks, well, society breaks down. That isn't what's happened, is it? What we've had is an outbreak of altruism, innovation, and community development with assets in communities, which has been truly phenomenal, which has reinforced what we believe is a partnership, which is that we have to start with the communities and the people who are in them and get things done by communities. So on the left there is, is a picture from a Hollywood pot boiler about what happens in these pandemics, and on the right is just a picture of a communication between one of my nurses and her mum about the dividers that she'd made for staff so that they could wear them when masks became mandatory, so that skin behind their ears didn't break down, which is incredibly painful. that tiny act of kindness has been played out right across communities. We go on to the next slide. As we go through this next period, it's news to many, but not to us. The inequalities persist, and the impact of the virus on our BME populations has been substantial, and it is being marked, and on other populations too. Some of that is due to inequalities. If you look at the graph there, that's just the likelihood that you will die depending upon which which sphere of income deprivation you're in. So the more deprived, the more likely you are to suffer from the virus and for it to kill you. And we know that the causes of that are not just about your health, they're about a whole raft of things that you can see on this graph. And as a partnership of councils, the NHS communities, commissioners and providers, we can do something about that, already were and will continue to do so. If you click on to the next slide, please. Fundamentally, at the heart of any future substantial changes that embed change and the reset of the health and care system and of society, we've got to talk about people. I've always been surprised, but not shocked, by our obsession with structure and system and the lack of understanding that we're a people business. We spend our money on people, people support people, and it's people that drive delivery every day. You know, their assets are what count. And my trust is made of people, the NHS is made of people, our partnerships are made of people, and the people have been magnificent, and they need our support in any reset. Just a couple of final things, three final things then. As we are planning for our reset, using our partnership to do so and building on the plans that we had previously, we will continue to use the leadership mantras that have served us well. We've drawn heavily on the work of Myron Rogers. Myron's worked in a number of countries, usually in post-conflict, and there are a couple of things there that I draw out particularly. Real change happens in real work. We've been doing real work and real change has happened. There's no point in pontificating about what we might want to do in the future, having a perfect plan. The only thing we know about plans is that they're not, you know, once you start getting into them, you need to change them. So real change happens in real work. Let's do real work. And the final one on that list, I think, is fundamental at this point. The process you use to get to the future is the future you will get. If you have a co-produced future that builds on the assets of people, that looks at health and care as an investment, not a cost, you will have services that are co-produced and deliver for people building on their assets, which come out as an investment, not a cost. So these leadership principles help to define the way that we work in partnership to deliver better outcomes for local people. The next final thing I'd say is that we've been working with the Academic Health Science Network on how did we get to the point where we've made so much progress, where we've seen so much innovation in the way services are delivered day to day, where digital futures are being adopted, where new service models are real. And how do we replicate those conditions for the future? Not do the tasks, replicate the conditions. And there's a report that we've published which has 7 different sets of findings about what's important and how we embed issues so that we can make change sustainable. I won't run through those in any detail, but you can see that supporting, engaging and working with vulnerable groups is essential, that leadership behaviours must be future focused and collaborative, and that the digital agenda alongside face-to-face basic care is an essential component of the future. The final thing I will say, if you flick on to the next slide, is we have, I think, been incredibly successful as a partnership because of 2 things. We have really good governance, you know, the rational world of decision-making, evidence and you know, empiricism, but we also have fantastic relationships between people with shared endeavours who like each other. And if we have both of those things in place, then we can have kind, empathetic, positive decision-making and service development, which is fit for the future. And I'll just finish with really a sense that, if you look at the last slide, coming out of this, all of the things that we had to address going into coronavirus are still there. Some of them are even worse than they were before, including the potential for the inequalities gradient to increase. But we have learned a lot of great things, and our resolve has been tested in the last 100 days in ways which should give us real confidence for the future. Thank you.
Rob, thank you very, very much for that. Excellent as always. The questions are coming in, which is fantastic, and we'll be bringing Rob back in about 15 minutes to answer some of those. If you've got questions, just to remind you, for those of you maybe just joining, do use the chat box. That's how we'll be selecting your questions at the end, and we'll be coming back to Rob very, very shortly. But first, just to introduce our final speaker on the panel, I'm delighted after some technology gremlins to see Katherine here today. So Katherine is the Chief Commercial Officer and MD UK and Europe for Healthy.io, a digital healthcare startup that leverages smartphone and cloud technology to offer access to the benefits of colour-based healthcare and medical imaging. What does that mean? It means that Katherine's innovation can help doctors to diagnose patients using images from a smartphone. Katherine has worked in healthcare for 26 years, 15 years in the NHS in both provider and commissioner roles, and 11 years with United Health Group, where she was the Chief Executive of United Health UK and latterly the Chief Growth Officer for Optum International. In terms of Katherine's company, it's been a tremendously busy time in the last few weeks. Katherine will tell you more in a moment, but by way of highlights, their wound care app was recently selected as one of the 5 innovations to be taken forward by the Welsh Government as part of an effort to use innovation technology in response to COVID-19 and beyond. They announced last week that they have acquired their main US rival. It's rare for an Israeli startup to acquire a Silicon Valley competitor, but in this case, that's exactly what has just happened. And Healthy.io was also recently named in CNBC's Disruptor 500 list, or 50 list, sorry, for 2020, which identifies private companies whose breakthroughs are influencing business and market competition at an accelerated pace. We've heard from Michael talking about a national policy perspective to reset. Rob has given us an exemplar breakdown of how an integrated care system and also at trust level looks to move beyond living with COVID-19. But we can't have innovation without our innovators, and Katherine represents one of our best. So Katherine is going to tell us her story of the last 3 or 4 months. Katherine, thank you very much. Over to you.
Thank you, Rob, and thank you very much for having me. Actually, we can go straight on to the next slide, please. I'll tell you a little bit about Healthy.io, and then I'm really going to draw out some of the challenges and some of the positives that have come out from the last few months, and my reflections on how we might retain what we've learned that's gone well and move on from what hasn't gone so well. Healthy.io is the first company in the world to be CE accredited for using the smartphone camera as a clinical grade diagnostic device. Founded by Jonathan Adiri in 2013, the vision was really that although there will be some major impacts in the forthcoming years from immunotherapy, from stem cell research, from genomics, from some of these big ticket items that one day will transform healthcare as we know it, that in reality, the largest investment in technology actually goes into the smartphone camera, and that's because of the 8 billion selfies that are uploaded to the cloud every day, mostly my children. And that if you could take that investment into healthcare, into the mainstream of healthcare, then you could actually drive transformation more rapidly than waiting for one of those big ticket items, or from the investment that the NHS has traditionally made in large scale infrastructure investments. You could actually get that transformation to happen not only more quickly, but also at low cost to the healthcare system, because the tech company is investing in the hardware and the software and the consumer's buying the device. So you should be able to actually make change happen rapidly, and it should be able to be done at low cost to a government sponsored system. So with that, we've created 2 product families. The first is digital urine testing. The second is wound care. Digital urine testing because it's the second most common diagnostic that happens on the planet. There are 42 million urine tests that happen in the NHS every year, and they currently involve often having to either use the facilities of your local healthcare clinic, or sometimes taking a sample in your handbag into your clinician. So not things that are particularly user and patient focused in terms of the process, but also something that can then be conveniently done at home using an app, which is a chatbot that talks you through step by step doing the test, and a kit that involves, in fact, the joys of video, I can show you one here, involves a pot, a dipstick and a colour board that you can then scan with your own phone, creates a clinical grade result substantially equivalent to the point of care analyzers in the hospital, and the app, which is so intuitive and so carefully talks you through doing the test, enables a 99.5% usability from 18 to 80-year-olds. So if you can text, essentially you can test. We were determined not to be the company that is the urine testing company, however, and so we've taken our ability to understand the differences in colour and how to measure those using an arbitrary smartphone in arbitrary light conditions to create a couple of plasters or band-aids that sit either side of a leg ulcer or press sore, and enable a little quick picture there, and enable a community worker or a nurse in the community to essentially measure a wound using the smartphone, get an accurate perimeter measurement, get a 3D reconstruction, identify tissue type using colour, and get then a standardised image in the clinical record that can enable expert clinicians like tissue viability nurses, vascular surgeons, GPs to see an image that is either asynchronously or in real time shared from the community worker. So essentially that's us and what we've done. Since before COVID, we were in 16 contracts in the UK, mostly in the NHS, some in retail pharmacy in the private, on the private side, some funded through Innovate UK, through research trials, some funded directly from the NHS, all of them relatively small scale, so quite a number of footprints. In urine, we have three main ways of looking at urine testing. One using 10 parameters, which is mostly in the hospital with renal, maternity and increasingly urology. One in which is a UTI test kit that's mostly done through retail pharmacy for uncomplicated UTI to take pressure off primary care. And the third is albumin to creatinine ratio, which is used in, provided for CCGs, ICSs, STPs, looking at population health to improve uptake from people with diabetes and hypertension in measuring kidney disease. So with that as a context, I'll move then into the next slide, which is where everything changed. So this is a flashback to the days where we were hoarding toilet paper, but perhaps not wearing as masks quite as often as shown in that picture. What I'll take you through next is some of the challenges that we've had since then and some of the positives. So moving on to the next slide, you can see from a challenges perspective, we had contracts that were ready to roll that just paused in March. So we had a contract with Dorset ICS. In fact, we have a contract with Dorset ICS that is for reviewing and supporting people with diabetes to take their albumin to creatinine ratio tests. And although there was a great deal of enthusiasm and encouragement from the ICS that they wanted to pursue, they simply said, we just have to stop now. We can't do this for another couple of months. Glad to say it's now kicked off again, but that was in line with some work we've been doing actually with the AHSN through NHSX funding to look to roll out ACR in Leeds and potentially Wakefield as part of some funding that NHSX had at the end of last year. And again, that was another one where we just were told we need to slow down. So everything that related to long-term conditions really just stopped at that point. And there have been several months then where people with diabetes who need their urine tested possibly are not having that done at all at the moment. There was promise of a centralised opportunity. We thought maybe this is finally the time where we get a big contract that comes nationally. This is the fantasy of all foreign companies as they come to the NHS, that there's some way that the NHS buys in a single way across the whole country. I came into this with my eyes open, knowing full well that isn't how it worked. But as Rob has described, there was so much work that needed to happen centrally in telephonic infrastructure, in Wi-Fi, in enabling the laptops, in making sure there were basic video and telephonic consultation, that I felt like the sort of innovation that we're offering is a step beyond that, and there hasn't as yet been a centralised opportunity to be driven into at the moment. All the research that I explained we're involved in was put on hold. So we've got a contract that's funded through the Burdett Trust, which is a research contract for looking at ACR rollout in Tower Hamlets that stopped and should be starting again in the next few weeks. And finally, I'll talk, when I come to the positives, about a real energy that we've seen from clinicians and managers in the trusts to actually embrace something new, a different risk profile, a different desire to get on with things. But what we have found is that surrounding that, the support services that enable a contract to actually get let, the legal, the procurement, the IG, the consent processes have got seemingly even slower than they were previously. So I have at the moment 11 contracts that are sitting in the final contracting stage, some of which have been there for multiple weeks. It's not a criticism. I know that procurement teams, for example, are very busy with very important procurement of protective equipment, of COVID testing, but it just feels that some of the innovation that also needs to happen is being kind of slowed down. So moving on though to the upside and the positives on the next slide, we have actually seen projects that have been slow for a long time suddenly leap into action. The same day that the RUH in Bath rang to say that they were very sorry the project had to go on hold because the research midwives were being taken back to the front line. This was a maternity project that we signed in July last year, and we were now at this point in March, and we still hadn't got it off the ground because of legitimate approaches to ethics and going through the processes we needed to go through to get all of the sign-offs. They rang to say unfortunately it was going to be postponed, but actually could they have the kits because they needed to give them to women on Tuesday. So we immediately had pregnant women in Bath now doing their testing from home, not having to come in to do blood pressure monitoring and urine testing at home. We've seen that shift immediately to remote outpatients drive a whole suite of opportunities, particularly in renal services for post-transplant patients, for example, who need to shield. And this has kind of gone hand in hand with, as I described, a kind of closing of the imagination gap. So 6 months ago, a clinician would say, this looks really cool, it looks really good, I can see why it could work, but the patient has to come in anyway, and it's really not that much hassle for them to bring a sample, and we don't think they mind using the toilets in the hospital. And no, they don't really mind the extra 30 minutes at the end of the session that it takes to do the urine test before they can go home. Wasn't a sort of a really kind of strong, compelling argument for clinicians that home-based urine testing would be adding value. Now that the patient's at home and they don't have other diagnostics to support their evaluation, to actually have the 10-parameter dipstick in clinical grade result in front of them in their electronic system, because the results go straight to the EMR, is a huge advantage. And we're seeing almost it's tipped on the head, where if the patient's at home anyway, here's all the great stuff we can now see about them. We've seen the growth in pipeline that's come with that, although I have to say very granular bottom up, still not huge scale, but a lot of interest in small scale. Let's try this, let's give this a go, let's make it happen. And then when we have been continuing to deliver with the patients on the ground, we've seen tremendous patient uptake. So take Sussex as an example. We were given 100 patients with type 1 diabetes who had not done their urine testing over the last 6 years. The consultant said, if you can get these people to do the test, we'll be amazed. We got a 94% consent rate, and 79% of those patients did their tests this year, which is just an extraordinary result. And of those, 17% were found to have protein, which is a first sign of chronic kidney disease and could otherwise have led to a real challenge. So last slide is just what I think we need to take from this. Oh, one more before that, I think, which slide missing. That's okay, I've got it in front of me here. So how not to waste a good crisis. How should the NHS reset use the learning from these two kind of positives and negatives for going forward? So I'd say we now have this video and telephonic consultation as a platform for the next level of innovation. We need to move from that basic level of communication digitally into the diagnostics, the wearables, the remote monitoring, the patient engagement that digital can bring. We need to take that engagement that we're now seeing of clinicians in technology to enable people and patients to make more digital choices. We've seen 92-year-olds using the digital test up in Hull when we were working with the HSN. We've seen people similar age down in Barking doing the test. We've seen it work across people from different minority ethnic backgrounds. The way that it's set up as an app is is at age 9 in terms of its reading age. It's really compelling and easy for people to do, and it's about really enabling people to use it as a default rather than as sort of an extra. Let's take that agility and speed we've now seen with clinicians and general managers who want to get on and want to move to digital approaches and bring that into the procurement, legal and contracting teams. Let's look for that sort of culture of urgency and preparedness that we've seen really emerging as a new culture that can actually drive change for the longer term. And let's use this digital platform to expedite and scale proven interventions. We talked about Wales, or Richard talked about Wales right at the beginning. Wales have basically taken an initiative to ask for help for COVID, to set out their parameters of what they want to take. They had 142 organisations put their hat in the ring with an offer. They ran a whole day of bid, and they shortlisted, ran a whole day of bid and pitch processes. They turned around within 3 days who was actually successful. They've chosen 5. They're going to do 6 to 8 week rollout with a view to scaling to the whole country from September. So it's a very rapid approach to actually taking things that are proven and actually giving them scale. And that's what I would love to see either. That's my challenge to Yorkshire and Humber, but also what I'd love to see happening in many places in the NHS. So I'll leave it there. Thank you.
Katherine, thank you very, very much for that. Absolutely brilliant. We're going to bring all our panel back in just 1 second, but just to remind you, as you can see there on the slide, do submit your questions and comments in the chat box. We have quite a few to be going on with for now, but we are keeping an eye on that chat box still, so please do keep them coming in. Katherine, as we bring Rob and Michael back, just to ask you the first question. I mean, really interesting, you talked about both the challenges there, but also some of the opportunities and the acceleration. Do you get the sense that our frontline teams are coming to you to fill an immediate gap in a temporary fashion, or are they looking at this now as something that's how we're going to do things in the future, or is it too early to tell?
I feel like once you close an imagination gap, I think the imagination gap is closed. So you can't kind of unbox that and now then say, oh, well, you know, actually, we don't need to. I think that's been the biggest and most compelling change for me, that clinicians are very clear. I would say that trust chief executives and people at really senior level have a macro view, which is I cannot go forward in the future with what I've now got because I haven't got the capacity to run the services in the way I have to for the new COVID times, and therefore I've got a really compelling need to change. The challenge is somewhere in the middle at the moment, where not the rest of the system hasn't kind of caught up with the enthusiasm of the clinicians and the big picture acknowledgement from the senior staff that there's something going to happen. And it's really about how do you navigate that bit in the middle, with what I'd say.
Yeah, thank you, Katherine. Okay, so our first proper question is coming to all of you. I'm going to start with you, Rob, first, but it's from Wayne Willis from the Edenic Group, or Edenic Group. Wayne asks, the future of healthcare needs to focus heavily on prevention and self-care. And
I can't hear you, Richard.
Oh, apologies. Am I still on mute? Can you hear me now, Rob?
I can hear you.
Okay. Well, Katherine, you might have to say this first if Rob can't hear me. But Wayne asks, the future of healthcare needs to focus heavily on preventative and self-care.
Yeah, you just faded out a bit.
Excellent. Story of my life. And to help society embrace this, the public should work with the NHS rather than rely on it. How does the panel feel about this point of view? What support is there for innovation to address these issues and change society's culture and attitude? So it's really about the prevention agenda, the responsibilities of the population as well as rights, and to a certain extent, how can innovation support that? Rob, do you want to pick that one up first?
So I would, so hopefully you can hear me, just give us a thumbs up. Yeah, good. So I liked Katherine's phrase about the imagination gap, and I think we've got to apply that imagination to what must it be like to be somebody with diabetes or COPD or autism or a learning disability, and to be told that you need to engage your condition more. I think I'd want to be quite forthright in my response to a system that felt like I wasn't taking my condition seriously. I think if we look at a different perspective, which is people live with their conditions and do so often despite the system, and that if we bring their assets to the conversation, then we could have genuine supported self-care, self-management and co-production, then we'll get better services. And I believe that what we've seen in this pandemic reinforces that in spades, because communities have come together to support each other, to innovate and to embrace changes in the way that care is delivered. So I think we as leaders have got to keep talking that up, and to recognise that for many people, they have the assets to engage, access services if we design them differently in ways which will be more impactful. And there's a digital way into that. As Katherine said, you shouldn't just presume that a 92-year-old not going to use a smartphone. I once visited an old lady in a tower block in Seacroft in Leeds, and she delighted in showing me the progression of her wounds on her mobile phone that she'd been sharing with her family. And if I thought they were bad now, I should have seen them last week, love. They were absolutely shocking pictures. But people have loads of assets. So I think we need to make sure that we take a different mindset and we close that gap, and we don't patronise people into thinking that we know best.
Michael, you mentioned about the round table that the Confed are running later today. I mean, anything to add on this in terms of the social contract with the population?
Well, I mean, we'll wait to see what comes out of that roundtable, but fascinating, and it'll link strongly to that point. And I would make 2 points on this one. And from a population health perspective, what are we doing with employers? And I don't mean us ourselves as an employer. I mean, actually, people want to be healthy, our citizens want to lead productive, prosperous lives. And actually, I think it's a really important point where, we should not own this population health narrative and its work. Actually, we should be working with our local employers as anchor institutions to support that. So I think there's something about supporting citizens to go about living their own lives. And linked to that is something which, through my reset work, I'm interested in the relationship between health and the high street. The high street is that symbolic centre of our communities where people go and they meet and they spend money and they talk. And often we have retrenched and taken our services away from where people and citizens do their daily business. And if our high streets are facing severe financial pressures, well, actually, what's our responsibility as a service, as a public service, to work with others, to be on the front foot and try and support this. And part of that is delivering services, but part of that is supporting our citizens. So I will earwig on this afternoon's roundtable with interest, but I think for me it's a great example of let's go to our communities rather than expect them to come to us.
I just want to bring in, before I bring in Katherine, I just want to bring in a contrary view. I mean, Dr. Janet Underwood from Health Watch Rutland has written in, and Janet says, quite rightly, the use of technology seems to be creating a different group of people experiencing health inequality. What did the panel think about this? Rob, I know you just made the point of saying we need to not assume, but I guess there is a question here about access, isn't there? Katherine, from your point of view, how does an innovator address some of those challenges in terms of communities who may be at risk of widening health inequality as a result of an uptick in innovation?
Yeah, so I think Rob mentioned already this need to not underestimate the use of smartphone cameras and smartphones in the population. And actually, there's clearly not everybody does have a smartphone, not everyone can use a smartphone, but actually the smartphone is probably more ubiquitous now. The highest number of adopters are in over 75s at the moment, and it can almost be seen as the leveler that is actually more accessible for people who perhaps otherwise wouldn't be able to take half a day off work to go and see a doctor, or travel because the costs of making a trip on transport to get to where their clinic is. And there's ways that it can offset other inequalities as well as potentially have a risk of increasing others. We've done a lot of work in the most recent rollouts that we've done to really be supporting patients who don't have a smartphone to actually engage with others that do, to enable them to still do the tests. So we had multiple occasions where our call centres rang back at the weekend when the daughter was in the house because she had a smartphone and she could help, or actually, you know, really be quite lateral in thinking about what ways can we engage to ensure that, if possible, we can get somebody to be able to do it digitally, even despite the fact that they might not have the machine themselves. So I think it's something to keep an awareness of, but I think if you think globally, you know, and particularly some of the developing countries, actually the smartphone is this platform that is an enabler to actually accessing healthcare in a way that isn't necessarily easy from their social and economic circumstances otherwise.
Thank you, Katherine. My next question, I think, is definitely coming towards Rob, at least in the first instance. It's from Anthony Blackburn, and Anthony says, demand for carers has tripled throughout the COVID-19 pandemic. Are we prepared for this increase in demand across local communities? Rob. I'm hoping Rob could hear that question. Over that, was thinking very hard about the answer. Are you struggling to hear me there, Rob?
So I didn't hear the question. I just heard the word carers.
Well,
try again, honest, Richard. I think I can hear you again now.
I think you just need that prompt, but it's from Anthony Blackburn. It was demand for carers has tripled throughout the COVID-19 pandemic, and are we prepared for this increase in demand across communities?
So I think. Okay, so I think from lip reading and partial hearing, I think the question, just not if this is the question, I think the question was demand for carers has tripled during the COVID crisis. What support are we offering? So we know there are 260,000 people who care for somebody in West Yorkshire and Harrogate because they love them or they feel a sense of duty towards them. And they've been disproportionately impacted by shielding and by you know, some of the restrictions on our daily life. We put in place a range of things to support them and prioritise this as one of our programs. It was already a priority programme in West Yorkshire and Harrogate, and we prioritised it further, particularly those looking after shielded and vulnerable people. So we've put in place Plan B schemes for everybody to give them advice on what's your Plan B if you become ill. We've given hospitals in the mental health and acute sector support for how you.
Oh, we might have lost Rob for a second there. Let's just see if he comes back. Okay, we might have lost Rob for a minute then. In that case, Katherine, I'm going to come to you with Natalie Poole's question. Natalie, oh, Rob, are you back? Rob, we're just losing you a second, Rob.
I think I was lost for some of that, but unfortunately.
You were. It was. I'm sure it was absolutely, you know, Gettysburg-esque in terms of its standard. But I'm just going to move on to Katherine. Katherine, a question from Natalie Poole. In your experience, what is the biggest barrier to adoption of these innovations?
I think it's a cultural issue about the level of commitment is the wrong word. It's about the environment within which it's permitted to invest in something new and scale it and learn from the process of getting it done and not be at risk of getting it wrong or being told that you've done the wrong thing in some way. So there's a really strong inertia around not wanting just to actually take a risk of making something happen at scale. So even where I have beautiful health economic evaluation that Yorkshire and Humber funded, HSN funded for us, showing that we could save the NHS £209 million in 5 years if we only got to 30% of the diabetic population who have not done their test in the last 12 months. Every single ICS and STP and CCG wants to start with one PCN and one little test just to make sure, even though the GPs of Hull are on video on my website saying how this saved them time, the GPs of Yorkshire don't want to go full throttle into Leeds because maybe it will take the GPs more time. So it doesn't seem to matter what level of health economic analysis, usability, clinical summary, trials, every angle you come at, everything that's kind of written down in evidence, it still starts with the randomized controlled trial in my trust and the 400 kits that we'll just try in this little subspecialty. Now I'm embracing that, and I've got a whole plethora of small pilots, but it just is what does it take for the NHS to say now, okay, we can see with all of this evidence and all of this validation, and I'm not saying for a moment that anybody should have done anything before we've done that and created the platform, but how should people be empowered then, be able to then make a bold decision about actually moving with it and not risking that sort of sense of, and I think it just is this feeling that they'll be in trouble if they do it somehow.
And Katherine, just to follow up on that, I mean, obviously as an HSN, that's exactly the space we operate in, but from an innovator's perspective, slightly frustrating perspective, I think it sounds, not surprisingly, what would you do? Is this genuinely a cultural issue that requires hearts and minds? Is there a policy lever to pull? What's the rapid way that we can tackle this?
So, I mean, the NHS does respond very well to mood music. So there's very often a sort of feeling that this is the thing we're being expected to do that then drives people to do it, whether, I think if there are places that can exemplify that, then that would be great.
Thanks. Rob?
More informed view.
So I think there's a simple thing here, which is part of the problem, which is where decisions get taken. And one of the really positive things about COVID is that in our trusts, in our systems, we're being crystal clear about where decisions get taken. And the fact that we have daily meetings where you can escalate issues for a decision means that things just happen really quickly. And at the moment, because it's not, in some places, it's not being clear enough, then it allows people to obfuscate and say, well, so-and-so won't like it, or there's a cultural problem here, when actually it might just be we need to be in the room together to make the choice together. And one of the learnings from COVID is, I think our trust will continue with the daily huddles, the bronze meetings now, but let's call them daily management huddles to keep on top of the business and make quick decisions.
Thanks, Rob. A big question from Wendy Tyndale. Hi, Wendy. Wendy from Sheffield Teaching Hospitals. Wendy says that it's almost inevitable that wave 2 of COVID-19 will come at some stage. Given the panel's experiences and what we now know, what would your advice be to the system and individual organisations and leaders as to how we can be best prepared? So a big question about the inevitability of wave 2. Rob, do you want to start with that? I presume this is part of your thinking. Oh, I'm hoping Rob's been able to hear that question. Go on, Michael.
Yeah, before Rob.
Well, Michael's got his hand up. Why don't you let him go first, and I'll come in on the back.
I was going to say there's something coming back to the fact that actually, if there is a second, a second wave, actually this isn't just an NHS thing, is it? This isn't just a thing which will hit us. And actually, I think you're seeing now, across the country, less of a national push and more of a local push. And I think it's absolutely vital that yes, we have crafted a stronger system within our health and care colleagues, but we've broadened this to understand actually what are the impact, what's the economic and social impact, much more wider than just what we do, because that is a fundamental part of how our place rebounds and recovers. And so I think for me, using the time now, we've got far more economic data of the impacts now than we had before. We are experiencing, and with that health leadership role of our impact. I think we need to make it understood how we will respond to what the impact is on us and our staff and our communities in the minds for our local economic leaders. And we need to understand actually what it means for our businesses and what it means for our other public services. So we've got a chance now that people have experienced this from a citizen perspective, from an industry perspective, from a health perspective, a chance actually to come together and understand, well, the future of our place depends on us all responding and leading from our various positions. And I think, a real focus now on just the interrelations locally will stand our place in good stead, wherever that place is.
Thanks, Michael. Rob, do you want to pick up on that?
Sorry, Richard, were you asking me to come in there? Okay, so I'm still getting a bit of Michael's wisdom coming through. I think we should go into the future with confidence. Really, I think we've got, you know, from a health and from a care and from a local government perspective, we've got people who are used to managing in crisis, and what we've also got, I think, is now some better coordination across systems. And I think systems like ours, I think this has really tested our strength and we've come out well. What I think would be better, the big thing that would make the biggest difference, will be to get the balance between what's done centrally and what's done locally right. We found that we've had to really coordinate some of the work nationally, locally, on testing, on PPE, on some of the mutual aid, you know, so some national systems and frameworks we've had to really make work locally together. And I think there's a balance between what's done centrally and what's done locally. If we can get that right, if we can really get that right, I think we've got a good chance of being agile enough to deal with the issues that face us. And in doing so, if we build on the work that's already gone before, and we should be in a good place.
Thanks, Rob. Katherine, from your perspective, you know, how could the system be better prepared for a wave 2, and also from a company perspective, have you given thoughts to your response to future peaks?
Yeah, I've got a beautiful document that I produced that is my offer to what we're trying to think of the right word for it, but it's almost like a winter vault. It's like the stash that you need to see yourselves through the, you know, like the hibernating animals, putting everything out there ready to get through the winter, which was kind of, you know, I think rolled into this question, isn't it? Because the wave 2 and the winter are all likely to come as one. And that's really about, you know, taking these small pilots and actually getting to the scale. I mean, I'm going to sound a bit boring now repeating what I've been saying previously, but actually there's so much more potential to actually embed this early stage of here and now we have a virtual and digital way of talking to people. Actually, this is now what needs to underpin that to make it sustainable for the long term, and to potentially even make it even deeper in terms of more people being enabled to be seen and supported in a home or local environment and not having to travel and not having to come in to a facility in that time. So, you know, we're ready. We're just needing people to come and engage with us on what that could look like, and to make sure that that is thought about ahead of time and not done as a last minute, you know, no process flurry because there's another crisis hit.
Yeah. Good time for
Sorry, Richard, can I just add a couple of other,
please, Rob.
Just a couple of other quick thoughts on this one. So I think getting the mirror held up to what we've done so far will help for the future. So it's really grateful for the work of the YHSN in us thinking about the lessons so far. And we've also got to plan for different scenarios, and we're working with the military on, you know, what do you do? Because lots of different things could happen in the next few months. And let's really stress test what we think is going to happen and what our resilience is going to be.
Thank you. We're going to have just one more question, and it's actually from me to the panel, so I'm going to take chair's prerogative to ask a question, but it's about sustainability. I think one of the things that you know, we've talked about a lot today is about the requirement, the necessity of COVID producing change so rapidly. We're also very conscious that never before has a single system and government been focused on one single challenge for such a length of time. And that obviously has been part of the advantage of being able to make such rapid changes so quickly. As we do move to something approaching, and I hate to use the phrase because it's now a cliche, but the new normal, and both government's attention, but also the system's attention, turns to that wider lens again. How sustainable do you think is this culture of transformation that we have seen? Are we going to lose our ability to rapidly make change at scale, or are there things that we need to sustain now that's going to enable that to continue? So I think, Rob, if it's okay, I'll come to you on that one first.
Well, there's huge risk. We're dealing with, we're dealing with people who are in a period. You learn in a period of discomfort, don't you? And we're all facing a period of extreme discomfort, through which actually some things are getting better, but some things really aren't. And we mustn't lose sight of the fact that some things that we've fought very hard for over a long time have got a lot worse, like the amount of time people wait. So we're going to have to try and address that. So I think we need to keep this question at the forefront of our minds about, I think you said this, Richard, and I repeat this a lot, what are the conditions that have allowed us to innovate, and how do we keep those conditions rather than focusing on the specific innovations? And then how do we apply those to some of the other challenges that we've now got around things like cancer, about inequalities and so on. So I think that requires the usual stuff around a bit of vision, a bit of collective will, the right sort of incentives, and regulators who are going to support innovation, not the status quo.
Thanks, Rob. Michael?
I mean, it's at the heart of reset, and this is one of the reasons why we're so keen to face the national, but also the local perspectives. And that's understanding that actually a system reset in West Yorkshire will look and feel perhaps different to a system reset in Dorset, and that's fine. That's absolutely not only is that fine, that's quite appropriate. And so we are trying to provide that cushion, I guess, and look to support both ends. What I would say about system leadership, and Rob personifies this really well, is the more you share and understand the externalities of what we do, the more you understand the influence you have and just how important this is. And so I think if I understand that actually the success and prosperity of my place depends on my actions as a health leader, wow, that puts a really different light on what I'm doing. And I think we're seeing a real focus on the anchor institution concept and others coming up. But the more I have the conversations and the more COVID brings me into touch, not just with public service, but other place leaders, I think the more I see that intrinsic importance and role I have, and then actually the harder it is to disassociate yourself from that, because this is why I invest my time and my money in my kids' future in this place, because the success and prosperity of it. And I think COVID really will have brought place leaders together in different new ways, which actually is exciting. And if we can hold on to some of that, then I think the cultural change can come.
And Katherine, last word to you.
So you alluded right at the beginning that I've had sort of 3 legs to my career stool. So 15 years inside the NHS, management trainee to PCT director, then 11 years in a big American corporate, and now the last 3 years in a Israeli digital tech startup. And so I've seen different cultures in those 3 places. And I have to say the joy of the place I am now, where there is a really fine line that's trodden between assurance, quality assurance, regulation, ensuring that we're clinically sound because we're in a highly regulated space, and the agility to be really flexible and move and transition and change and adapt. Is just this, it's a joy every day to be in this situation. I've seen some of that agility and change really emerging in the NHS in the last 3 months. And I don't think, a bit like my previous point, that you can put a lid back on that, because once people have tasted it and seen it, it's not something that you sort of forget and go, oh, okay, now I'll go back to doing what I was doing. So the real challenge for me is how do you bring the whole system into that mindset? We kind of know now that the NHS has this in its DNA. How do you maintain that culture every day? And I know it can be done because I sit in an organisation where that is the culture. So it's not like a sprint. It isn't something that just requires a kind of the headless chicken running around. It can actually be cultivated within a systemic kind of deliberate culture. So that's what I would love to see, and I think that's going to be a huge opportunity for the NHS as a whole to be sustainable for the long term.
Thank you, Katherine. Perfect way to finish there. So thank you very much. Thank you so much to my panel. A few IT gremlins, but I think we just about got through it. So thank you, Katherine. Thank you, Michael. Thank you, Rob. Thank you to you for joining us in your hundreds. It's been hugely appreciative, and thank you for your questions. Thank you also for your contributions on Twitter. Do keep following the debate and contributing to the debate on Twitter. Use the hashtag NHS Reset, but also look out for our own Twitter handle at YHAHSN. There will be some feedback questions that will be coming out to you very shortly. As always, we do hugely value your feedback, so I'll be very grateful for you to fill those in, please. As I said at the start, a video recording and also the slides from today will all be made available to all delegates before the end of the week, and an email will follow on that. So that's all from me. I'll leave you all to enjoy the rest of your Wednesday and hopefully see you again on a webinar in the near future. Bye-bye.